Okay.
Yes, ma'am.
So, okay. So let's go to the, sorry, this screen where everybody is showing up. So it's blocking my view. Anyway, come on now. So let's go to the first case that I had shared. This is a 3-year-old male child with loose stools for 1 year. D2 showed nodularity on upper GI endoscopy, and a duodenal biopsy was taken. So, who wants to discuss this? Anusha, should we
Yes,
start
ma'am.
with you?
Yes, ma'am. Sure. Thank you, ma'am. Section show a duodenal mucosa with preserved villus architecture, but there is a blunting at one end, and the villi are broad and lined by tall columnar epithelium with interspersed goblet cells. Crypts are normally number and morphology, but here we are seeing there are the numerous prominent lymphoid follicles occupying the mucosa and extending into submucosa, and show well-formed germinal centers with a mantle zone consistent with reactive follicular hyperplasia. So in these two images, actually I couldn't make out the plasma cells. So my DDs are one is nodular lymphoid hyperplasia, the other one is considering the age, there may be some immunodeficiency associated enteropathy also, maybe a gamma globulinemia, ma'am.
Very good. So now, but first let's come to your description. So you said that there is normal villus pattern, right?
Yes, ma'am.
And you did say that there it appears to be blunted in some areas, correct?
Yes, ma'am. Yes,
Yeah.
ma'am.
So now, tell me, Anusha, how should we comment on the villus pattern? When should we comment appropriately on the villus pattern in a duodenal biopsy?
Ma'am, generally, in celiac diseases and all, also we'll see the villus atrophy.
Yes,
So,
but should we, is there something that we should ensure in the way the sample is before we comment on the villus pattern? Otherwise, we may make mistakes. In this case, it didn't really matter, and you're probably right. It's more or less normal, but it's not a optimum or suitable biopsy for the comment on villus pattern, right?
okay,
So
ma'am.
what is a suitable biopsy when we should comment on villus pattern? What should be the orientation of that biopsy? See, you can see these villi here, but
Yes,
can you
ma'am.
see the muscularis mucosae here?
Mm, no, ma'am.
No, you can't. And normally the villi,
Yes, ma'am.
then crypt, and then the muscularis mucosae, right? And
Yes,
also
ma'am.
the
Yes, ma'am.
crypts are usually parallel to each other, correct? So here they are
Yes, ma'am.
haphazardly arranged, partly because of the lymphoid follicle, correct?
Yes, ma'am. Yes, ma'am.
So
Right.
when we are looking at this, so we can say that the villi appear to be normal. However, this is not an optimum biopsy for comment on villus pattern. And wherever it is a little blunted, a lot of those areas it is blunted because of the presence of lymphoid
Lymphoid
follicles.
follicles.
Yes. So that is an artifactual blunting. Okay.
Okay, ma'am. Okay.
Correct.
Okay.
Very good. So now, as we go down, we see this again, the lymphoid follicles, which you have very nicely described, correct? And then the blunted villi, but these are all artifactually blunted.
Artifact. Okay,
Yeah,
ma'am.
okay. And then, is there anything else you are seeing in this, which maybe if you manage to see the absence of plasma cells, then you have increased the magnification, and that means there's something else here that you should have seen. Is there anything else? I think this slide was shared with you, right?
Yes, ma'am. Yes, ma'am.
So in this, can you see anything else? When you are looking at an immunodeficiency, what are the other thing you should try and look for in a duodenal biopsy? Besides the presence, the lymphoid follicles which you've seen, that has prompted you to look for the presence or absence of plasma cells, correct?
Yes, ma'am. Reduction of
So,
plasma cells will be there.
yes. So
Absent of plasma.
now, what else should you look for? Is there anything else? I'm going to see if I can enlarge it and move it down. Okay. Can you see anything over here? One sec, I'll just get the pointer. It's enlarged in your field also?
Yes, ma'am.
Okay. So now let's see. Can you see something happening here? What is this
Is it
area
H?
called?
Is it
Intervillous
H by the inter?
space. No, what is this?
Those are apoptotic bodies. What are
No,
they?
no. Now look over here again. Yeah. All these.
Any
Yeah. What is the organism that you can get in these intervillous spaces and very commonly associated with
Giard
Giardia?
Giardiasis, ma'am.
Correct. So
Yes,
this
ma'am.
is Giardia,
Giardiasis.
right?
Okay.
So this
Okay.
is a case, you have very correctly said that there is absence of plasma cells. So now let's take a look at the next slide. Why is it not going to the next slide? Yeah, here, this is a higher part, and you can see the presence of this Giardia trophozoites. They are seen. What are the forms that you see of Giardia, the shapes that you see of these Giardia trophozoites?
Pear-shaped. Pear-shaped.
Yeah.
Okay.
Okay. So we have this pear-shaped ones, and then you have these sickle or spindle-shaped ones, right? So
Yes, ma'am.
depending on whether it is a flat or end-on cut. So these are the Giardia trophozoites. We're seeing colonies, and in fact, in an immunodeficiency, Giardia will never be just 2, 3 lying somewhere. There will be colonies of Giardia, right? Because there's an immunodeficiency. So that is what we are seeing in this case.
Okay, ma'am.
And this is another case where there is again presence of a lot of Giardia in the intervillous places. And another thing that you are seeing over here in this particular slide, do you want to comment on the intraepithelial lymphocytes?
There's an increase in intraepithelial lymphomas.
Okay, so what do you think? Why is there an increase in intraepithelial lymphocytes? So even
Because of infection.
giardiasis, can show a patchy increase in intraepithelial lymphocytes. Okay, what is
Yes.
the pattern of increase of intraepithelial lymphocytes that we see in celiac disease? Because mind you, celiac and giardia can also coexist. Okay, so if there is celiac disease, what is the pattern of increase of intraepithelial lymphocytes that you see? Where are they present in the villus? In the base, in the tip, on the sides,
In the
where
tip,
should they
ma'am.
be? In the
Tip
tip,
is the
correct?
predominant.
Yeah.
Yes,
So
ma'am.
you should see increased intraepithelial lymphocytes in the villus tips.
Villus tips.
And in giardia, often you may see a patchy increase or a focal increase of intraepithelial lymphocytes with or without any mild villus blunting. But in this case, this is a different case, the one that you're currently seeing on the screen. So the previous case that we saw, I don't think there was an increase in intraepithelial lymphocytes, but there were a lot of lymphoid follicles, and there was the presence of the absence of, so what stain is this? What are we trying to look for?
Giardiasis.
For
No,
giardiasis.
giardia we have seen. Why are we going to stain for giardia? Giardia we've seen. You said that you did not see any plasma cells.
Plasma cells.
Right? So we are going to try and look for plasma cells and make sure that we are not seeing them. Right? So what stain can we do for plasma cells? If we want to confirm that there are no plasma cells seen, then what stain, what immunohistochemical stain can we do for plasma cells?
CD130.
Yes, CD138. Okay. So if we do a CD138, where are we seeing the staining in this case?
Ma'am, generally it will show the strong membranous staining.
Where? What are the structures here that are showing the staining, these structures? These structures are they lymphoid or epithelial?
Epithelial.
Yes. So CD138 does stain membranous in the epithelial
Membranous.
cells. So that is like a positive control, which is very important. If this was totally negative, how do you know if your stain has worked or not worked? Correct? So you
Control should be there.
really have a positive control on the same slide, or if there is a positive control in the tissue, then that is in fact ideal. Okay, so here these epithelial cells act like a positive control because there is membranous staining. And here where all the lymphoid cells are present, we are seeing that there is complete absence of staining.
Absence of staining. Yes, ma'am.
Correct. So this is the CD138 stain. And you are right, there were no plasma cells in this case. And so what diagnosis can we make? An immune profile has to be done for the patient. You are right. And so this, what we said was in the report that this is nodular lymphoid hyperplasia with giardiasis, and the histological features are suggestive of a common variable immune deficiency, in which case plasma cells are often absent, right?
Yes, ma'am.
So,
Yes, ma'am.
but however, this has to be confirmed by the immune profile of the patient. But this is very suggestive of common variable immune deficiency disorder. Okay.
Yes, ma'am.
So this, there are other immune deficiencies which you had mentioned when you were describing it. So like IgA deficiency and common variable immune
Gamma globulin.
deficiency. Yeah. And then you can have, of course, with this Giardia as well as any other immunodeficiency disorder. You can get Helicobacter pylori infection in the gastric mucosa, which can be associated with CVID also. And lastly, there is a risk of lymphoma in these patients. So these patients have to be kept on a close follow-up. Now, the next case was a 2-month male with Hirschsprung's disease, and patient was operated and a colonic segment was taken out for sent for histopathological examination. Anuj, you want to describe this?
Yes, ma'am.
Yeah. I hope you haven't seen the case in our in the department. No?
No,
Okay.
no.
So you can describe it then. Yeah.
Section 7
I think
showed.
this is one of the slides which was shared, right?
Yes, ma'am.
Yes, ma'am.
Section 7 showed tissue pieces of colonic mucosa showing ulceration of colonic epithelium. Lamina propria show moderate mixed inflammatory infiltrate comprising of lymphocytes, polymorphs, and plasma cells, along with congestion and hemorrhage. Focal cryptitis and cryptapsis is also seen, and few cytomegalic cells with oval eye intranuclear viral inclusions are present. It is infectious colitis that can be CMV due to CMV.
Okay.
Cytomegalovirus.
Very good. Excellent. So in the next slide, I think you can see the cytomegalic cells with cytoplasmic and intranuclear inclusions. Did everyone manage to see these? Was there anyone who did not see them? Anyway, it doesn't matter. Now you see them. So you have to be careful when you are seeing. Now the other thing was, okay, let's go back to what is Hirschsprung's disease? Tell me. What do you expect to, or what are you looking for when the segment has come to you for Hirschsprung's disease?
Ganglion cells.
Yeah, you are looking for ganglion cells, right? For the absence of ganglion cells.
Absence of ganglion. Yes, ma'am.
So if the ganglion cells are not seen, now that depends on what? When you get a segment of colon, what all part of the diseased segment do they remove? What do you think? Suppose they've taken out rectum and sigmoid, And this is Hirschsprung's disease that is involving the lower 5 centimeters or 4 centimeters, right? So they've taken out rectum and sigmoid. What do you expect to see grossly in the specimen? And then how will you take the sections? Anuj?
Yes, ma'am. Ma'am, gross. Ma'am, mainly there is a, narrow segment which is dilated proximally,
Hmm.
and it is a mainly funnel-shaped specimen.
So where will you
And
take the sections from?
mm,
Where do you expect to see
ma'am,
the ganglia?
from the at the sleeve of at the submucosa and mucosal end, we will take the section.
No, no. This is a full resection specimen that has come to you, right?
Yes, ma'am.
Now, how are you going to take the sections from which parts of the rectum and sigmoid? Or let us say there is, you said it's funnel shaped, there is a distal narrow part and a proximal dilated part. So, where do you want to take the sections from and what do you expect to see in these sections?
We will take section from both the proximal and distal margin, and we
Hmm.
will paint at the time of taking section. We will paint a certain margin, so we will get to know it's a distal section, and we
Hmm.
will mainly look for a ganglionosis on the distal margin, more probably.
Okay. Yeah. So, and what do you expect to see in the proximal area?
Normal anatomy.
Okay, the proximal area is dilated or narrow?
It's dilated. Proximal is
Yeah.
dilated.
So in the proximal dilated segment, you do expect to see ganglion cells, and in the distal narrower segment, you do not expect to see
Yes.
ganglion cells, right?
Yes,
And
ma'am. Yes.
ideally, you take a full section
Yes,
and you
ma'am.
paint every proximal end of that section so that you can actually measure the length and say which is how much of that segment was had absence of ganglion cells and from which part the presence of ganglion cells appeared. Now,
Yes, ma'am.
what if we are, who else is there? Nidhi. Nidhi, we have not asked, right? Is Nidhi present? Komal? Komal is there?
Yes, ma'am.
Komal. So tell me when they are making a diagnosis of Hirschsprung's disease and they want to do biopsy in the child, what is the sort of biopsy that they should take, the clinician should take?
Ma'am, 2 centimeters.
Above 2 centimeters, not below 2 centimeters.
Yes, ma'am.
Right? And what sort of a biopsy? Because you're looking for ganglion cells. So, what sort of a biopsy do you want? If they take, what does a normal biopsy of the rectum or sigmoid show you? Normally, what does a biopsy show you? The mucosa and muscularis and a very tiny bit of the of the submucosa.
Yes,
So, you may not see ganglion cells there, right? So, what sort of a biopsy do they take?
ma'am. Transmural, which involve the muscularis mucosae also, because
Yeah,
we
so
want to
they
see
call
in
it
the mind
suction or pull
plexus.
through biopsies. Okay, so those biopsies which will have some segment of the muscle, they are taken, and ganglion cells are often fewer in the submucosa and much more in the muscle. So if you do not see ganglion cells in a biopsy, you have to take multiple serial sections to make sure that there are no ganglion cells before you say that the ganglion cells are absent. Okay.
Yes,
What stains can we do for the ganglion cells? Special stains?
ma'am. Acetylcholine
Yes.
and
And
calretinol.
Kills
acetylcholinesterase is done in what sort of
frozen.
section? Yeah, frozen section, right?
Yes,
Whereas calretinine can be
calretinol.
done in the routine paraffin embedded sections. Okay.
Yes,
So now this is an example of a submucosa where there aren't any ganglion cells, and here a muscle where you are seeing nice ganglion cells, right? So rectal mucosal biopsies, no ganglion cells identified. It's Hirschsprung's disease. the case I've shown you, not the case I gave you. Okay, that was not actually Hirschsprung's disease, but just a little bit about Hirschsprung, because this is the presentation of the patient. They thought that the patient had Hirschsprung's disease. So they are much more common in boys, and total colonic aganglionosis is less, fortunately. It is less common, but in total colonic aganglionosis, girls are a little more frequently involved, not than boys, but than they are involved in the other types of aganglionosis. So there is a functional obstruction, dilatation, and you can see this 80% of the cases have total are just in the distal segment. There is aganglionosis, whereas 10% have it in the right side of the left side of the colon, and 10% have total colonic aganglionosis. These are the various ways to diagnose, and this is another case of the gross finding, narrow segment, dilated segment, and then you're looking for ganglion cells. This is positive ganglion cells on calretin. And here on H&E, you can see the absence of ganglion cells in a nerve fragment. It's also associated with what change in the nerve? Often?
Hypertrophy.
Yes. Yes. So, but in this case, now coming back to this case, we did not see that. Instead, we saw these cytomegalovirus inclusions.
Yes.
Yes. And how can we confirm that?
By IHC, CMV IHC, we can use.
Yes, we can confirm it by CMV IHC. So these are those inclusions in Hyper, and CMV IHC was done. And where do you expect to see these cytomegalovirus inclusions? In what cells? Komal, what cells should we see these in?
Ma'am, I don't know.
So will they be seen in epithelial, endothelial, stromal fibroblasts? Where should they be seen?
Endothelial cells.
Endothelial cells
Endothelial
and
cells.
Mesenchymal cells and in macrophages also they can be seen.
yeah, you can see that in the stromal fibroblasts. You can see it in endothelial cells very commonly. And what is the common condition in which we look for CMV colitis in adults? The common condition which routinely we have to look for CMV colitis in adults.
Immunodeficiency.
Ma'am, I transplant receipt. Immunocompromised.
Immunodeficiency.
But immunocompromise is not common, right? So I'm saying common condition.
AIDS, HIV.
Use of proton pump inhibitors.
No. In IBD, in inflammatory bowel disease, often they are given immunosuppressive drugs, right?
Okay.
They're given steroids, they're giving immunosuppressive agents, and therefore in IBD patients, UC or Crohn's disease, on follow-up, if you see a severe colitis, then it is mandatory to do test for CMV and to look for CMV on H&E, because that is a very common cause of severe colitis can occur. Why? Either the patient is not responding to therapy, right? So the patient is not going into remission. And one of the other reasons could be that the patient has now a superimposed CMV colitis. Okay? So CMV colitis is more in your day-to-day practice. You see it much more frequently in IBD patients on immunosuppressive therapy than you will see it in general in a patient who is immunocompromised, right? Because that is much fewer. It's a rarer condition. So this was a low power picture. It was just teeming with CMV. I've never seen so many CMV before. Okay, now coming to the next case, who will discuss it? Who else is here? Krupa is here. Ramni, Sandeep, who is here?
I'm here, ma'am, Raman.
Sorry?
Ramani, ma'am, I'm here.
Okay, Ramani, good. So 7-year-old male with chronic diarrhea, and this is the photomicrograph. These two photomicrographs were shared, right? Would you like to describe this?
Ma'am, there is crypt, elongation and
What is
irregular
this? What is this biopsy of? What part of the GIT?
colonic biopsy.
This is colonic. What do you see in the colon? Okay, let us see this area. Is this seen in the colon? You have two parts of this. One is this upper part and one is this lower part, right?
Yes, ma'am.
Now, Ramni, just describe this upper part. Now what you are seeing without worrying about anything else. Whatever you have written earlier, all that, forget that. Now tell me what you are seeing in this field.
Gastric biopsy.
Okay, why do you say gastric biopsy? But I actually asked you for your description. Your voice is not coming clearly.
Okay, ma'am. I think it is viola C.
Foveolar cells.
Yes, ma'am. Foveolar
Yeah,
cells.
so what do foveolar cells look like? What are these cells looking like? So forget what foveolar cells look like. Tell me what these cells look like. Just describe these cells here. Okay, just these few cells here. Just describe them. Are they cuboidal or columnar?
They are columnar.
Columnar. Where is the nucleus?
Nucleus is basal.
Basal nucleus. And on top of the nucleus, what do we have?
There is, it looks like a vacuum.
So there is a mucinous cytoplasm,
Sinus.
right? This is
Mucinous
mucin. This
cytoplasm.
pinkish light pink thing is mucin, right?
Yes, ma'am.
So there's mucinous cytoplasm. These are columnar cells, and these are the foveolae of the stomach. And as you go down, these are what type of cells are these? Are they looking the same as the ones above? No. So these are specialized cells. Okay, in stomach, which part of the stomach between the cardia, fundus, body, antrum do you get these foveolar cells on top and then the specialized cells at the deeper region? Where do you get this? No, you get them in the fundus and body. Okay, in the antrum you have less of these specialized cells and more of mucinous cells even in the base. Okay, now what are you seeing here? So now this is a gastric biopsy, okay, from the gastric fundus or body. Now what are the pathological features that you are seeing in this gastric biopsy? This is a higher power view. What are the pathological features you are seeing in this gastric biopsy? No? Garima is here? Garima?
Yes, ma'am.
Do you want to say what are the pathological features we are seeing in this biopsy?
Ma'am, there is ma'am, marked inflammatory cells
Okay.
that I can see, ma'am.
What sort of inflammatory cells are these?
Ma'am, eosinophilic and ma'am, there are lymphocytes and eosinophils.
I don't see too many eosinophils. Some
Ma'am, there,
plasma cells in the lamina. Where are the eosinophils? In the lamina propria or in the epithelium? They're in the
ma'am, in the
lamina propria.
ma'am, lamina
Okay.
propria.
Okay, there are some few eosinophils in the lamina propria. Then
Yes,
what
ma'am.
are you seeing in the epithelium?
Ma'am, in epithelium, ma'am, lymphocytes.
Correct. So there are lymphocytes in the epithelium. Is this normal?
No, ma'am.
So what do you think is happening here? There is an increase in the number of
Of
lymphocytes in the
intraepithelial
epithelium.
lymphocytes.
Yes, but this is not
Ma'am, normal
duodenum. This is stomach.
stomach.
Correct? So
Yes,
what
ma'am.
is this called then? Let's see the next slide. Now here again, there are a lot of
Intraepithelial
lymphocytes,
lymphocytes.
right?
Yes,
In
ma'am.
the epithelium. Here again. Okay, these are just some extra slides. Okay, so
Yes, ma'am.
there is a lot of lymphocytes in the epithelium. You can sit and count them, but there are lots. And then we did a CD3 stain, which is also identifying all these intraepithelial lymphocytes as T cells, right?
Yes, ma'am.
Okay, so what is your diagnosis then?
Mm, mm,
Is there
Ma'am,
some
it can.
inflammation in the stomach?
Yes, ma'am. Gastritis.
So there is a gastritis. What
Yes,
is
ma'am.
happening? There are a lot of lymphocytes, right?
Yes,
In
ma'am.
the epithelium where they should not be. So what can we call it?
Lymphocytic
Absolutely.
gastritis.
Lymphocytic gastritis, right?
Yes,
So
ma'am.
this is lymphocytic gastritis. This is another CD3 stain. So this is lymphocytic gastritis.
Yes,
Okay.
ma'am.
Now, like in celiac disease, when there are increased number of lymphocytes in the epithelium,
Yes,
then
ma'am.
we count them and say how many are there, right? So similarly, in the surface foveolar epithelium, now normally there are only 3, 4, 5 intraepithelial lymphocytes. But in many conditions, they can increase a little bit. But when they are more than 20 to 25 per 100 epithelial cells, then we can call it lymphocytic gastritis. Okay, again, these are CD3 and CD8 positive. CD8 is a marker for which type of cell? Which type of T cell?
Helper cell, T helper cell.
CD8 is what?
Toxic.
Helper or
No,
suppressor?
cytotoxic.
Toxic, right? Okay. Now, the other conditions when you can get this is H. pylori gastritis. In that too, you can get increased IELs, but more commonly, what do you get in H. pylori gastritis? Lymphocytes are rarely seen, in fact, in the
Neutrophils.
intraepithelium.
Neutrophils are seen.
Neutrophils. More commonly in H. pylori gastritis, you get neutrophils, you get cryptitis, pit abscess, but you can get lymphoid aggregates and follicles. Now, in Crohn's disease, there can be upper GI involvement, and in that you can get lymphocytic gastritis. You can get it in autoimmune gastritis, you can get it with medications like NSAIDs, then you can get it in HIV, and Crohn's I've seemed to have written twice. I think celiac was what I was meant to be writing. Okay. So in celiac disease also, you can get I'm in a meeting right now. Thank you. So in celiac disease also you can get increase in intraepithelial lymphocytes. Okay? Yeah. So in the stomach, duodenum में तो होते ही हैं. How many, what increase is called increased IELs in the duodenum in celiac?
More than 30.
More than 30, correct. So more than 30 IELs per 100 lymphocytes, per 100 epithelial cells is increased in the duodenum, correct? Okay. Now this is a section of what part of the GIT? बताओ. ये किस टाइप का म्यूकोजा है बताओ जल्दी
Stratified squamous.
Squamous, correct? This is
Esophagus.
squamous. So this must be esophagus,
Esophagus.
correct? And here also, if you see carefully, there are increase in the number of lymphocytes that are
Lymphocytes.
present intraepithelially in the esophagus.
Yes, ma'am.
Good.
So you can get esophageal lymphocytic esophagitis also. A prerequisite is that you should not have neutrophilic inflammation in that. So you
Okay.
cannot have neutrophils and lymphocytes, then the lymphocytes are just there with, it's not lymphocytic. Okay? So in the absence of significant neutrophilic inflammation, if you get increase in the lymphocytes in the esophagus also, that is, see, this is CD3 stain, strongly positive, and that is intraepithelial lymphocytosis in the esophagus. It is much higher number, usually more than 20, some say more than 50. It's not very well defined. You should not see neutrophils or granulocytes, and there may be some epithelial damage. Again, this is now lymphocytic esophagitis, and again, pretty similar the etiology as lymphocytic gastritis. Okay?
Yes,
Now,
ma'am.
coming to the next case, which is a 4-year-old child with blood in the stool for 4 months, daily or multiple times, multiple times, 10 to 12 in a day, with pain abdomen, and a video image was shared with you. Clinical suspicion was of IBD, UC, or Crohn's disease. So basically, inflammatory bowel disease.
Yes,
And
ma'am.
this is the video image. Did you manage to see it as a video?
No, ma'am.
Yes, ma'am.
Yes, ma'am.
No, ma'am. Yes, ma'am.
No, ma'am.
Chalo. Anyway, some of you did and some of you don't, but the video did not, I think, show anything very much, just went around the same area that you're seeing here. It's not letting me move it as a video here either. So now who will tell me about this? Is Krupa here? Nilofer? Garima?
Yes, ma'am.
Yeah, you want to describe this?
Okay.
See, we already know it is a 4-year-old child, sorry, with pain abdomen, blood in stools. And so what do you think this is a biopsy of which part of the intestine?
Blood in this, ma'am. Colon.
Colon, rectum, one of those, right?
Yes,
Okay.
ma'am.
So now what are you seeing here?
Ma'am, marked inflammation in the colonic segment,
Yeah, correct.
along with ma'am, what I can see is a necrosis.
Okay. So this is sort of an exudate or necrosis
Yes,
that's
ma'am.
lying. Yeah. And even here, right?
Yes, ma'am.
Okay. Anything else? So you can enlarge the slides, na? Like this when you get them on your PowerPoint. Anything you're seeing here in this field? Have you written anything else when you have initially seen the slide? Garima?
Ma'am, no, ma'am.
Okay. Now what are you seeing in this field? Anybody else has seen anything else in this?
Trophozoites
Tell me.
of
Trophozoites of
Entamoeba
Entamoeba
histolytica.
You saw it earlier?
Yes,
Or you're
ma'am.
seeing it now?
Yes, ma'am.
Earlier.
Okay, be honest,
Earlier we
okay?
have seen
So now these are trophozoites of
trophozoites of
Entamoeba
Entamoeba
histolytica. Correct?
Yes,
Okay,
Yes,
ma'am.
ma'am.
anything else? Would I give you a case with just trophozoites of Entamoeba histolytica?
Spirochetes were also there. I have a query. Spirochetes.
Yes,
Doubt.
you are right. So here, look here. There are so many neutrophils, which of course can be present with amoebiasis. You often see neutrophilic ulcers in amoebiasis. But what are we seeing here? A fuzzy border. Can you see this fuzzy border?
Yes,
Which
ma'am.
is not
Yes,
normal,
ma'am.
correct? This fuzzy border if you see this fuzzy border, you need to rule out the presence of spirochete infection. Okay? And how can we rule that out, or how can we confirm that? By what stain? Yes, yes.
From what silver stain?
Warden starry silver stain. Correct. Okay? So Warden starry stain can be done to confirm this. So, sorry. Okay, so what do we have now? We have hematochezia in a child with multiple biopsies from colon, clinical diagnosis of IBD, and we expect to see features of chronicity with ulceration. So let's go back. Are there any features of chronicity in this?
It's
What are those features?
is slugging, slugging, crypt abscess.
No, so crypt abscess and necrosis are features of chronicity or activity?
Activity.
Activity, correct? So activity can be in any acute colitis. What are the features of chronicity in inflammatory bowel disease? That was their diagnosis, clinicians. So what should we be looking for in, if we want to, Bolo?
Distortion of crypt artery.
distortion of
Distortion.
Okay, distortion of crypts. Anything else? A severe
Crypts,
acute
atrophy.
colitis can also cause some amount of
Basal.
crypt architectural. Yes. So you need to have
Plasmacytosis.
basal lymphoplasmacytosis.
Plasmacytosis.
Basal lymphoplasmacytosis is important to make a diagnosis of IBD, but we do not have that in this case. Where should we be seeing that? So this is the surface, this is the base. Here some muscularis, little bit threads we can see, not very well, but somewhere here should be the basal lymphoplasmacytosis, right? Which we are not seeing in this case. So we are not finding the classical features of IBD. Instead, we have seen amoebiasis in this, right? But if we look, there's a lot of acute inflammation and ulceration. So that is okay. That can occur in amoebiasis, a few amoeba sitting over here. That can occur in amoebiasis, that can occur in IBD, but we do not have the classical features of IBD. So we cannot call it inflammatory bowel disease. It is definitely an acute ulcerative colitis, correct? Or an acute colitis with ulceration with the presence of amoebic trophozoites so far, right? Plus we are seeing a fuzzy border and we need to figure out. So these are the amoebic trophozoites, right? And what stain is this? PS stain. So should we do a PS or a PS with diastase?
PS.
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 What is the other stain we can do for amoebic trophozoites?
Groco.
No.
Groco.
That is for fungal.
Fungus,
Rocotte
that's a
silver
fungus.
stain is for fungal infections. For amoebic, what else
Trichrome.
can we? Sorry?
Trichrome.
Well, you're right in a
Trichrome.
way. Trichrome can be done, but a better stain then is a iron hematoxylin stain. Okay? Iron hematoxylin stain can be done. Okay. So we've seen these trophozoites, cryptitis, cryptapsis, etc. But there is something more. There is something more interesting in this, which was that fuzzy border. Okay. So this fuzzy border that we saw, we are suspecting it's a spirochete infection. And right next to it, we are also seeing these trophozoites. See? So this is a dual infection. These are those the fuzzy border and very distinct. It's not a diffuse fuzziness, it's very distinct fuzziness. So that gives you a very strong suspicion. Otherwise, sometimes even the mucin in the surface can give this fuzzy appearance, but it is more blending with, it's not distinct like each spiral form over here. So this makes it very suspicious. And then you do a Warden starry stain. This is another high power. And then you do a Warden-Starry stain, and when the Warden-Starry stain is strongly positive in these cases, and you can see some structures separately also.
Yes.
Okay, so this Warden-Starry stain can also be used for what other organism?
Ma'am, H.
H.
pylori.
pylori.
Correct. Okay, very commonly used for H. pylori. What are the other stains we can use for H. pylori?
Genta, ma'am, Dipquick, Jimsa, Elchian yellow.
We use a modified Jimsa stain. Okay, so a modified Jimsa stain is used. That is a 2% modification of Jimsa, not the Jimsa that we use in the hemat lab. Same stain, but prepared in a modified manner. Okay. Now the next case was a 40-year-old female with small bowel type diarrhea, and an endoscopic biopsy was done from the duodenum. So with small bowel type diarrhea, 40-year female, what are we thinking of? What are the common things that it could be?
Infection.
Crohn's disease.
Okay. Anything else? Why not celiac?
Ma'am, celiac too.
Yeah, you can get adult celiac. So it could be Crohn's, it could be celiac. Okay. Okay. Now what are we seeing here? What have you seen? Who else is there? Komal, have you described a slide?
No, ma'am.
The Komal, describe this.
Ma'am, section examined reveal mucosal lining epithelium. There is a conspicuous presence of the tiny coccydians at the apical surface. The underlying lamina propria shows a dense mixed inflammatory infiltrate. And my differentials can be firstly the cryptosporidiasis and
Correct.
ma'am, other we can think of according to the clinical details, these malabsorptive diarrhea in which we can see celiac disease, tropical sprue, Whipple's disease, but we have to further investigate the patient.
So you've already seen some structures over here, these tiny structures, very correct. These structures all over here. They are adherent to the surface and they are very small, less than 5 or 3 or 5 microns in size and adherent to the surface and dark in color, hematoxyphilic in color. And what stain can we do to confirm their presence?
Modified acid fast.
You can do modified acid fast. Anything else? You can do a simple Jimsa stain also. Okay. So when you do a Jimsa stain, this is just another higher power to show the organisms. I don't know where the Jimsa stain has gone. Anyway, maybe it'll come later. So this is Cryptosporidium pavum. And it's seen in the small intestine and colon, 2 to 5 microns, basophilic, at the apex of the enterocyte. And the stain is a Jimsa stain that we do for it. Okay. This is the Jimsa stain that is done, and it highlights them very beautifully on the surface. So now, why is it not celiac? Let's go back to the photograph. Okay. What would we expect to see in celiac?
Crypt hyperplasia.
Crypt hyperplasia, shortened and blunted crypts, villi.
Villi are short and blunted, and
Crypt
Intraepithelial
Intraepithelial
lymphocytes
lymphocytes greater than 20.
more than 30.
increased, which is not increased on the villus strips in this case, correct? These villus strips, few IELs are there, but we need them to be more than 30 per 100, which we are not seeing, correct?
Yes, ma'am.
Okay, why is it not Whipple's disease?
Ma'am, there is no foamy macrophages.
Correct. So you see and what do you stain in Whipple's disease? What do you stain it with to identify the organism?
Ma'am, pass stain.
Yes, you do a PS stain. Okay. Okay. Okay, so coming to, I think, the last or second last or last case, I think. This is a 14-year-old male who presented with complaints of chronic epigastric pain, nausea, and vomiting, and biopsy was taken from the esophagus and duodenum. Okay, and actually, I don't know what all I've shared with you, but he underwent multiple biopsies from the entire intestine. Okay, so what have you seen? Who is left? Who has not described a slide? Everyone has described one slide?
Yes, ma'am.
Okay, then we go back. Anyone wants to describe this slide? Anyone is
Yes,
very
ma'am.
sure of the diagnosis, so you want to describe it?
Yes, ma'am, I'll go.
Huh,
I'll describe.
who is this?
Anusha, ma'am.
Okay, Anusha, come on, tell me your description.
Ma'am, section show a esophageal mucosa with marked
Yes.
intraepithelial infiltration by eosinophils, many
Mhm.
of which are forming eosinophilic microabscess, and there
Mhm.
is a prominent basal cell hyperplasia. Eosinophils are seen infiltrating the superficial layers of epithelium and spreading like a sheet-like pattern. And the lamina propria shows mixed inflammatory infiltrate, which are rich in eosinophils. So my diagnosis are eosinophilic esophagitis.
Okay, very good. So when do you call it eosinophilic esophagitis?
Greater than 15 eosinophils in
Or
40.
yeah, or when there are
Hyperplasia.
eosinophilic microabscesses and in the absence of a significant neutrophilic inflammation again. Okay,
Okay.
because if you have a significant neutrophilic inflammation, these eosinophils could have just accompanied that. Usually they're still not that high in number, but still you should not have sufficient eosinophilic, neutrophilic infiltration in order to make a diagnosis of eosinophilic esophagitis. Okay, and then you have to exclude all other causes that may be responsible for this esophageal eosinophilia before you label it. So you have to look for an etiology. If you don't find an etiology, then it is esophagitis with excess eosinophils, likely related to that. Suppose there was a parasite or something, right? A lot of peripheral eosinophilia. But if you don't find that, then you call it eosinophilic esophagitis. Okay?
Okay.
Now you can also get eosinophilic gastritis. Okay? In eosinophilic gastritis, you need more than they say more than 30 eosinophils per hypa field. And it should be in at least 5 separate hypa fields, not in just one hypa field. Okay? And again, the absence of any known possible cause of mucosal eosinophilia. Okay? So, now if the patient has eosinophilic esophagitis and gastritis, what is the clinician going to look for?
Parasitic
Parasitic
Yes,
infections.
one is parasite, then
Ma'am, reflux, symptoms of reflux esophagitis or any GERD
GERD.
symptoms.
Any
well,
drug hypertension.
GERD can have an increase in eosinophils, yes, but then you can get some reflux features even in eosinophilic esophagitis.
Yes, ma'am.
Then you should also rule out things like eosinophilia and
Yes, ma'am.
else.
Any
Loeffler
drug.
syndrome. Loeffler's syndrome.
Okay. So a lot of other causes that can be responsible for eosinophilia. But when we want to call it eosinophilic esophagitis, that means it is the esophagus that is involved with the eosinophilia. And the other thing the clinician has to rule out, depending on the symptoms, is if there is a eosinophilic gastroenteritis,
Okay.
which is why they will then take multiple biopsies from different sites. Okay?
Okay, ma'am.
Now, this is another biopsy, duodenal biopsy of this patient. What have you seen here?
Two eosinophilic structures are there.
Okay, what are these? Where are they lying?
In the lamina propria.
Okay.
So some helminthic infection because there is
Yes.
a increase in
Cross
eosinophils
section.
also.
Okay, so this is duodenum. Marked increase in eosinophils here also.
Yes,
Okay,
ma'am.
and these helminthic structures which are actually in the crypt. They are not in the lamina. If you zoom in, then you see they are in the crypt.
Crypt.
Okay. Now these are strongyloides, larval forms of strongyloides. Okay. So these are larval form of strongyloides. And this is the colonic biopsy from the same patient. And in the colonic biopsy also, you can see marked increase in the number of eosinophils.
Eosinophils.
Okay, but now this patient has strongyloides infection. So this is increased eosinophils in the causing gastroenteritis in a patient with strongyloides. And what is the treatment for strongyloides? Something that they wanted to give us even in COVID. Ivermectin.
Ivermectin.
Okay, so ivermectin is given, and when you give ivermectin, now this patient was given ivermectin, and after the course of ivermectin, when the patient was followed up, the eosinophilia had decreased, the strongyloides, I mean, there were no larval forms now in the stools. You are not doing biopsies again and again, but the eosinophilia and his symptoms had markedly diminished. Okay, so that was the last case, and because of all the previous talks that I had seen earlier, so I had kept this very simple and taken things that hopefully in the previous talks the other people had not discussed, because those were polyps and upper GI, lower GI, this, that. But the aim of this little session today is to tell you that you must look very closely into the smaller details, because that is what can give us the final diagnosis. Okay, for example, in case number 1, you had to, which you did see, you had to see that there was giardia and there were absence of plasma cells. So that makes us tell the clinic, and mostly in nodular lymphoid hyperplasia and CVID, it is the pathologist who guides the clinician that this patient has nodular lymphoid hyperplasia, no plasma cells, please check for CVID. Okay. Then in the second case, what was the second case? Hirschsprung's disease, right? Ganglion cells, in fact, were there. And when you look closely, you saw the CMV inclusions. Okay. Then in the third case, in the stomach, the increase in intraepithelial lymphocytes. So it's only if you look closely at something that you will be able to identify whether it is that, or it is cryptosporidia, or it is spirochete along with amoeba. So you have to realize that sometimes they are red herrings, and you will never know that that is a red herring. What is a red herring? That just it's pointing you in the wrong direction. Okay. So even if you, so that's why it is very important to look at a biopsy in total to make sure that you are not just seeing one thing and not identifying the other, because in that particular case, there was an active colitis amoeba, which if it's in together, but it's only because you're looking carefully at a biopsy that you realize that there is that fuzzy border also, and we should look for spirochetes also. Okay. So one has to look very carefully and closely at all the biopsies, and it is very important to even look very closely at a biopsy that otherwise looks normal. In fact, to me, the most challenging biopsy is a biopsy where I cannot find anything. It looks quite normal to me, because the patient has got symptoms, the patient has undergone an endoscopy, a biopsy has been taken, there must be something. Unless they've just said to rule out something, and that's okay then. So the most challenging biopsy is a biopsy where the findings are very small, very minimal, or something that could easily mimic something else, and you have to look very closely and find out what exactly is the etiology in these cases. Okay. Do you have any questions? If there are no questions, we can close the session. Moderators can guide us if we should close the session now.
Madam, few doubts are there.
Yes, yes, please.
If only one colonic crypt is showing one neutrophil, then do we say it as cryptitis?
No, well, even if one colonic crypt is showing one neutrophil, you may have to call it cryptitis, because after all, you're just seeing a small biopsy. You don't know what's happening elsewhere, but that does not necessarily make it a active colitis or something. So you have to say what you are seeing. You have to call it, but you have to be very sure that you are seeing a neutrophil. So that little bit of cytoplasm around it should definitely be there.
Okay. Ma'am, another question is small intestinal diarrhea different from colonic diarrhea?
Yes, yes. Small, that is more a question for a clinician, but small intestinal diarrhea is different. It's often large volume, bulky diarrhea, sometimes watery diarrhea. So, and when the diarrhea occurs is also a little different. So it may be triggered by meals or not. So those sort of findings are different. So small bowel diarrhea is different from when you say the patient has, it's also more watery, less well-formed stools. You see, that's small bowel diarrhea. Better formed stools, even if they are loose, but better formed stools is usually associated with, and smaller volume is large bowel.
Okay. Madam, one more doubt. Sometimes it is very difficult to differentiate UC from Crohn's.
Yes.
So, which points will help us in differentiating that? What are the points?
So the most important thing, that's not, I mean, part of this, but the most important thing to differentiate UC from Crohn's, if we are talking about a biopsy, right? In a
Yes.
biopsy, the only thing that can really help you is the presence of a granuloma, because all the and the fact that there is patchy disease. Okay, so if your clinician has a diagnosis of UC versus Crohn's, the first thing is the clinician should have given you biopsies from multiple sites. Okay, biopsies from terminal ileum, rectum, sigmoid, ascending, descending colon, etc., and all sent separately in separately labeled bottles. Do not compromise in that. If they put everything together, no, you cannot. They cannot then ask you to make these diagnoses. Okay. Second thing is, so now you look at all of it. Is it more of a distal disease? Or is it more of a proximal disease? Distal disease, where there's more activity and chronicity in the distal parts, then that is more likely to be UC. Proximal, more likely to be Crohn's. If it is a patchy disease, that means some fragments show disease, some don't, then it is again more likely to be Crohn's, not UC. Finally, granuloma. Okay, so if you see granuloma, then of course you have to look carefully at the granuloma. Is it a small microgranuloma that is about the size of a crypt or 100 microns, not necessarily very well defined, although this is not an all or none. Okay, this is usually it's like that, the granuloma in Crohn's. And you be very careful to see that is this granuloma associated with the crypt which has crypt abscess. Then take deeper sections, see is that crypt rupturing and causing this granuloma. Then it could be a granuloma, cryptolytic granuloma, that is seen in ulcerative colitis. But if that is not the case, it is just an intercryptal microgranuloma, then it is likely to be Crohn's disease. And believe me, it is still very challenging, however much you may know the differences. So it's always based on clinical, radiological, and then finally, histology does play a very important part.
Thank you, madam. And how do we follow up these cases? How frequent they do?
So, which cases?
This IBD patients, UC and CT
IBD
patients.
patients, it's usually very much dependent on the clinician and how the patient is responding to treatment. So if the patient is responding well to treatment, then they do not do a biopsy that frequently, maybe once in 6 months or 1 year. But if the patient is not responding, then they may have to do a biopsy, an endoscopy, and then a biopsy again earlier in order to see what is the reason. Is there a CMV colitis? Patient is responded and then had a flare. Then again, they want to see why is that flare there. So how much is the activity? So then 3 to 6 months, I think they will follow up. But the important follow-up is after 8 years. I mean, till now, it is a follow-up based on the disease activity or remission and to assess that. After 8 years, the follow-up is now in order to see is there any dysplastic change or neoplastic change. Okay, so that is a different thing. Then after 8 years, they are followed up based on other risk factors, either once a year or once in 3 years, based on whether the patient has other risk factors, which is like family history, this, that, a lot of other things. Okay, so whether they have pancolitis, how severe was the disease earlier, is there any family history, then they may have to be biopsied once a year. If none of the other risk factors are there, like they don't have primary sclerosing cholangitis, they don't have any of this, then they are followed up maybe once in 3 years.
Thank you so much, madam. There is one more question. Where to look for the organisms in the biopsies given?
Everywhere. So if you have exudate, you look in the exudate, look for amoeba on the surface, look for any organism stuck to the surface on the whether it's a spirochete or a cryptosporidia. If it's duodenal, you will look at the intercryptal space for giardia. That's the most common. In H. pylori, again, you will look in the surface mucin and on the surface of the epithelial cells. In a parasite, it could be anywhere, right from the lumen to the crypt. So once you make a habit of taking one good look at the entire biopsy, you will not miss these things. You will pick it up because they are not common, but you will pick it up because you've made it a habit to look at the entire biopsy carefully once, completely in 10x or 20x at least, not just in low power, and it just high power is also doesn't help, because in high power you're going to miss certain areas. So you have to look at it very carefully in an intermediate power, pick out the area where you may want to look in high power and then go there.
And madam, do all these organisms cause tissue reactions like lymphocytes and plasma cell increase in the lamina propria?
A lot of them do cause it, but different organisms can cause different things. Like the parasites will cause more of eosinophilia. Amoeba will cause more of acute colitis type of picture. And some of these cryptosporidia, etc., may cause very little reaction. There may be just some mild increase in lymphocytes, plasma cells in the lamina propria of the duodenum, where in any case there are a fair number of lymphocytes and plasma cells. Same with giardia. There may be some non-specific increase in IELs. There may be some mild villus blunting, but they may not. So these ones may or may not cause too much change.
Cryptosporidium and giardia. Okay.
Yeah, whereas H. pylori will cause usually active, gastritis as well as lymphoid follicle formation.
Madam, another question is, in a duodenal peptic ulcer, what other points to be included in impression?
Question is in the sense, now if you've got a duodenal ulcer, a duodenal peptic ulcer, so you're talking about a biopsy either from the duodenum or from the stomach, right? Now, if you're talking about a biopsy from the stomach, suppose, usually then you must mention the degree of chronic gastritis, like the Sydney system. You must mention the degree of activity, pititis, pitapsis, ulcer, or just neutrophils in the lamina. Then you must, of course, look for H. pylori. You must look for other features like any other atrophy, autoimmune gastritis, etc. So look for atrophy, that and any metaplastic change. These are the various features you'd include in your report. In a duodenal ulcer, you would comment on in a duodenal biopsy, you would comment on the nature of the villi and the IELs always, and then whether or not an ulcer is present, whether you can see any cause for the ulcer.
Okay. Thank you, madam. Another question is, in a biopsy removed as diminutive polyp, sometimes you don't see any abnormality. What do you report it as then? This is common. This is a common
Well,
thing, madam.
look very
Regularly we
carefully
get it.
in a diminutive polyp. Look very carefully if there is a lymphoid aggregate that is causing that polypoidal thing. Or if you are seeing in a diminutive polyp, say in the duodenum, a little bit of Brunner's gland hyperplasia. So first be mindful of what are the small things that could cause this diminutive polyp. Sometimes it's just edema that is causing the polyp. So first just see these features and then you can say that there is no well-defined polyp, but these are the features that may be causing a polypoid appearance. And if you're seeing absolutely nothing, which is not uncommon, yes, then you just describe it as it is and say that there no definite polypoidal lesion is identified. And that does happen. Sometimes, in fact, recently we had a case, there was something that looked like a fairly large polyp. When they took a biopsy, there was no polyp. But they had taken it from that polypoid region, which they showed us on endoscopy. So that was just a healing area. So for us now, we may not be able to call it a healing area, right? So we have to just describe what we are seeing. So we said that this is what we saw. There was no definite polyp and we just saw normal crypts, little bit of inflammation and fibrosis, but no well-defined polypoidal structure was seen. So they are looking for a polyp which has significance, whether it's an inflammatory polyp or a hamartomatous polyp or a neoplastic polyp. So even telling them that those things were not there is good enough for the clinician. So you have to go back and forth with your clinician to understand what they want. When you know what they are looking for, then you can tell them, yes, that is there, or no, that was not there.
Okay, thank you, ma'am. Sometimes it is difficult to differentiate that ischemic colitis from the pseudomembranous colitis. Both will show this membrane and exudate on it. So at that time, what should we do?
See, there the history is very important. Pseudomembranous colitis has to have that history of having taken these antibiotics, correct? And in ischemic colitis, in pseudomembranous, usually you see much more exudate, and in ischemic you will see the like an infarcted appearance of the epithelium. So the shadows of the epithelium may still be remaining, of the epithelial cells and the morphology of the epithelium. So that you see more commonly in ischemic, whereas in pseudomembranous, the history is very important, which is why we cannot, give any reports in isolation. So you have to have the clinical details.
Thank you, madam. Thank you so much. It was an excellent session. And
Thank you.
I hope there are no more questions coming up. So we shall wind up the session. And we would like to have you again, madam. More.
Thank you so much. Thank you. Pleasure
Thank
is all
you.
mine. I hope the
Thank you so
students